Thank you all for joining us today for another episode of our podcast, Moving to Value Unscripted. My name is Dr. John Rodas, and I'm a recovering ex-hospital president, and I'm proud to be the president of the Moving to Value Alliance. The Moving to Value Alliance, MTVA, a 501c3 organization, is a multi-stakeholder grassroots community whose purpose, put simply, is to create a community that aims to create a value-based healthcare ecosystem with high-quality outcomes at a reasonable cost for plan sponsors and their members, beneficiaries, or employees. Our community has grown substantially over the past few years. We started in Connecticut, but now have nearly 1,000 members from more than 40 states all over the U.S., and our members include many value-based influencers. I want to thank our sponsors whose support makes this presentation possible. We'd like to give a special thanks to our trade member sponsor, Connecticut Joint Replacement Surgeons, LLC. We're joined today by my fellow board members, Lisa Trumbull and Dr. Steve Schutzer. Lisa Trumbull is the CEO of Sohn Health, Southern New England Healthcare Organization, a physician-led clinically integrated delivery system in Connecticut and Massachusetts. Dr. Steve Schutzer, a nationally renowned arthroplasty surgeon, one of the founders of MTVA, and is a co-founder and president of Upswing Health. Our special guest today is Ge Bai. Dr. Bai is professor of accounting at the Johns Hopkins Carey Business School and a professor of health policy and management at the Johns Hopkins Bloomberg School of Public Health. Professor Bai is a nationally recognized leader and expert in healthcare accounting, finance, and policy. She's published extensively and has testified before Congress. Welcome to Moving to Value Unscripted, Professor Bai.
Thank you so much, Dr. Lotus. What an honor.
So, G, I'm going to start with an easy question for you. As I've gotten older, I've noticed our life paths are rarely straight. So tell me how a young woman who went to a great school in China studying engineering and Japanese literature ended up studying accounting and getting a PhD in accounting in Michigan. Fill in the gaps for our listeners.
Sure. Thank you, Dr. Lotus. So I came here when I was 25. Now I'm 45. That's 20 years ago. I came actually as a trading spouse. So my husband got a scholarship from University of Michigan. We're classmates in college. So I came without any idea what I'm going to do because I have a spouse visa. I'm supposed to come here as a spouse. Then I got really bored, and luckily, my mother really, sponsored me for my graduate education. She said, just pick a useful major, and then you'll go for it. Then I saw business school because my undergrad is in kind of trade related. So I look around. I feel like accounting is quite useful, right? Everybody hates it, but it's useful. Why don't I take that? So I took accounting. Then I got my CPA license. Then I worked for a Japanese company because of my language background in Michigan for a year. And I got bored. I think there might be more innovative things for me to do. So I applied for a doctoral program. Then I spent 5 years in Michigan State accounting doctoral program. Then I got placed in Washington University in Lexington, Virginia, it's a liberal arts college. And the opportunity came business school in Johns Hopkins. But at that time, my accounting research led me to hospital data. Why? In accounting, we want to, at least in my governance focus, we want to know board composition, board trustees. There's no such good data except for hospitals. That's how my exposure to healthcare data started. And it was amazing. And I looked around, nobody's looking into these issues, and there are so many issues. So that's how I changed from accounting researcher to a healthcare researcher.
Oh, God bless you. Because listen, as an ex-hospital president, I can tell you, hospital finance and accounting is not simple, not simple math. So, we've spent a lot of time on this show and trying to understand the whole pharmacy space and spend. And, most employers are spending 30 to 40% of their total healthcare spend on pharmaceuticals, as you know. And it's the most convoluted from an accounting and finance and can't follow the money trail. This is probably one of the more complicated things in the world. And you only have a few people purchasing the drugs and a few people distributing the drugs and a few people in the PBM space. And everybody seems to be taking a piece of the pie. And I guess I'm going to start with a broad question of PBMs in general. How did we get here? Pharmacy, the whole idea of pharmacy benefit management was, hey, we can leverage our purchasing power to get the best price for drugs, and then we could pass that savings onto our employers and beneficiaries. But that doesn't seem to be the case. Tell me a little bit, how do you think we got here?
So PBM started purely from the market. It's not a government appointed or government designated agency, right? So the market needed PBM. It started in 1956 by some pharmacists in Canada. So they formed this organization exclusively to manage pharmaceutical benefit because they realize it's pretty complicated. It's hard for any other entity to manage. So why don't we focus on that exclusively? Then over the years, PBMs have been owned by various entities. So for example, McKinsey bought it. That's in the 70s, I believe. And then in the early 90s, drug companies bought it, like Merck. And then there's some antitrust concern. That's why pharmaceutical companies can no longer own PBMs. And then we have CVS, which is the largest pharmacy, about their own, or started their own PBMs. And then we have Cigna owning Express Script. We have United owning OptumRx. So the three largest PBMs. So we have this interesting three big names owned by either pharmacy or by insurance company situation. So it's a long involvement, but it is the product of the market. And I think many people, especially on the insurer side and plan sponsor side, we have a lot of concerns about PBM. However, there's no other way, right, not to use them, at least for major players, because PBMs do have this unique expertise in drug benefit management. Because we have so many drugs, that's a reality. But then because PBMs are controlling money from all the entities, so let me specify, they're controlling revenue for drug manufacturers, right? They control revenue for pharmacies. They control spending for patients and plan sponsor. So you can imagine because they're so powerful, nobody likes middlemen, right? Everybody has a concern about the role they play. But I do want to emphasize that if we look at Part D premium change for the past 10 years, Part D premium, which is Medicare drug benefit premium, actually grows at a lower rate than inflation. So that tells us, just from the plan sponsor perspective, PBMs do bring down premium to some extent. However, if we look at patients, we have a huge problem, that is the sick subsidizing the healthy, meaning that the patients pay co-insurance or co-pay based on the list price of the drug, but the list price so detached from the net price, and the PBM taking a cut, right? The gross price or list price higher than the net price. This is called difference, called rebates, and PBMs take the rebates and give all or a big portion of it to plan sponsors and keep some portion of it. So PBMs have a natural tendency to prefer high list price, high rebate drugs. And that leads to patients paying a lot of out of pocket for those drugs.
Right.
But then the plan sponsor got the rebates back. They don't really share with patients. So patients end up in a situation that the sick patients subsequently healthy. So that's number one problem. Number two problem, if you look at the generic drug space, many insured patients end up paying a higher out of pocket for common generic drugs than if they pay by cash. What happened is because PBM is making money, right? It's called spread pricing. Buy low, sell high. So they pay the pharmacies at a lower price than they charge from plan sponsor. So then the patients, again, pay based on whatever the plan sponsor and the pharmacy, agreed, and PBM agreed upon. So patients pay, in many cases, higher out-of-pocket price than what they can buy in a cash pay arrangement. For example, GoodRx, for example, Mark Cuban Cost Plus Drug Company, which use a unique perspective, like circumventing PBM to deliver a closer connection between the drugs and the patients. So overall, I think we have to look at the patient's cost sharing as a very serious concern, but at the same time, we have to recognize the PBM play a very unique role in controlling premium to some extent.
So it sounds like, G, that PBM started with very noble intent, right? 30 years ago. And this may be a byproduct of the consolidation of forces and so-called vertical alignment, where they've amassed such control.
Yes.
How did that happen?
Yes.
And then I don't quite understand, how is that permitted? Because you read about this stuff in my business and John's as physicians, we could never get away with this type of consolidation. How did this evolve?
Partly because the nature of PBM industry, Steve. So when a sponsor evaluates the PBMs, the sponsors care about the rebates, right? Again, the rebates is different between gross and net price. If the rebate is higher, the net price is lower, so the plan sponsor felt that will reduce their premium. So if, let's say I'm a PBM, Steve is a PBM, I'm one of the big three, and Steve is just unknown alternative PBM. So a plan sponsor will think me as more powerful, as more like a bigger and have greater marketing power, so that I can extract a bigger rebates from pharmaceutical companies. So that's a natural belief, right? Bigger, more market power, better able to get rebates. So that's the nature of PBMs negotiating business, right?
Yeah.
So, and then second, think about CVS. I'm taking CVS because CVS also owns the pharmacy, right? Biggest pharmacy. So they have Caremark as their PBM, and then they have their pharmacy. Another concern is the independent pharmacies can survive or not. So for example, in a market, if the PBMs owned by the CVS Caremark, try to reduce the reimbursement for all independent pharmacies. Let's say extreme case, put them out of market. They cannot survive. Then this whole market is captured by the CVS Caremark, right? So, and then that's what I think many concerns right now from the pharmacy industry saying we are really being killed by the PBM owned by pharmacies, and there's no way for us to break it.
Yeah. Ge, one of the questions that I have, it's interesting to look at the evolution of the pharmacy industry. And I would say, this has happened across the industry, not just in the pharmacy space, but it's probably more acutely felt in the pharmacy space by patients and employers, because when we look at total healthcare expenditures, pharmacy costs, drug costs is escalated, in double digits each year, to a point in some cases where it outstrips inpatient costs. And that becomes unsustainable for the employer, unsustainable for the patient, unsustainable for society. So when you look at the industry, given your expertise, what do you think the solutions are? What do you think the federal government should be looking at? And how do we address this? Because clearly you can get the same drugs in other countries for far less than what we pay here in the US.
Yes, thank you very much, Lisa. I think we have to look at the drug pricing from branded versus generic, two very separate perspectives, right? So this is very hot debated topic on the Hill right now, right? We have a lot of members, very interesting topic. However, I have a relatively neutral perspective regarding the players on the supply chain. We have amazing pharmacies. But pharmacies also need to make money, right? Pharmacies cannot survive if they don't make money. And then in this fight between pharmacies and PBMs, we have to say both parties try to squeeze money from the supply chain. Evidence just not sufficient to support that. If we limit one party and the other party will eventually deliver a lower price to patients. So I always hold this view like there's no sin, there's no villain. It's really about a power struggle, right, between the two parties. So I think when Congress or any state governments design policy, they have to look at who they're trying to benefit. If they're trying to benefit patients, I think they should look for evidence showing if we weaken PBMs, the money coming from PBMs will actually go to patients, not go through pharmacies. The state level, a lot of regulations are actually pushed by pharmacy lobbies, right? But then again, there's just not enough evidence that patients will actually benefit. However, I would say who's really having the skin in the game? The employers, right? Employers, they're paying dollar for dollar, right? After deductibles met. Right. And employers have a huge concern. They think PBM is not giving them the right rebates. They think PBMs are putting the wrong drug on the formulary, end up spending more as a result.
All
so
true.
I think at minimum, right? At minimum, Congress should help employers get at least auditing right. Many employers don't even know. Even if they want to know the claims, even if they want to see exactly what drugs being spent, the PBM don't give that to them. Why? PBMs are very powerful. Why should I give that to you if you cannot escape, right? You cannot leave me. If you leave me, let's say you change from Caremark to other PBM, you're gonna see change, right, on the benefit, and your employees gonna get confused. They'll not be happy. So basically, I have all the cards in my hand, so I don't give you the deal. What can I do, right? So that's a common issue. And if you employer tell me, gee, I don't like this drug beyond my formula tier 1, this is a very expensive drug. I want it to be tier 4. I'm like, no, you cannot do that. Well, I have a lot of leverage. So that is a thing I think Congress can help, can give more leverage to the employer, and then let the employer choose what to do.
Yeah, I think that we've talked about this, of course, on the show, and we've had, entire episodes wrote to transparency and the Consolidation Appropriation Act and trying to encourage employers to get their data, because employers at the end of the day, and employees, by the way, the ones who really are paying the bill, we call payers, which I hate it when we say the payers, and we're really talking about these third-party administrators. They're not paying anything. It's the employers and employees. So geez, I'm listening to you. I'm thinking to myself, oh my God. And I listened to recently our friend Stacey Richter's podcast with you about the, and I think she used the word monopoly, but it's really, I guess, I'm Greek, so I have to use the Greek terms, oligopsony of purchasers. You only have 3 major purchasers. You have oligopsony of sellers. You have only three wholesalers. I mean, it's kind of crazy how several people dominate all ends of this food chain. Are we better off going back to a system where doctors actually wrote a prescription, give it to the patient, and said, here, use, GoodRx or shop around and go pay cash for your drugs directly at the pharmacy? Would that be better?
100%, in my opinion. Right now, most of the pricing issues come from one root cause. That is, patients are detached from their healthcare dollars. Right? If we can bring patients closer to the caregivers, I mean physicians, put them together as close as possible, many of the problems will be solved. Not just the generic drugs. We think about brand name drugs. Think about weight loss drugs, right? Now weight loss drugs actually have their direct pay channel, like Lilly Direct, etc. So it definitely can work. Patients can just get the prescription from doctors, or even doctors can run their own pharmacy, right? Doctors can supply those drugs. I think that'd be much better model. However, then the question comes about access, that quality. But I would say once we get rid of the middleman as much as we can, the premium will plummet. It will be much smaller, and then we can use the money to put into HSA or other subsidized channel to help patients pay, or in stop loss insurance. Right now, our system leaves many people in medical debt, and also our system believes those middlemen, including PBM, especially PBM, that believe these middlemen have a genuine incentive to reduce price. There's no way. Let's say I'm the middleman. My revenue really depends on spending. If the spending cut half, everybody, let's say extreme case, everybody's healthy, not using any medical care, I got no money. Why would I want that to happen, right? I have to make sure spending goes up every year. That's how I make money. So this is a fundamental perverse incentive I think our public and policymakers should recognize.
Yeah. Gee, 20 years ago when we started talking about generics, there was high hope that it would disrupt the industry, right? I mean, that's what generics do. That's the whole idea. There's no R&D, there's not all of the patents that are around that. What happened? What happened to generics? I mean, they're not part of the solution. They're actually part of the problem.
But Steve, I would say only if you go through insurance, right? So if we get a premium, Amazon premium, I'm not trying to advertise for Amazon, but if we have an Amazon premium, we have access to Amazon Pharmacy, which gives us $5 per month coverage of all common generics, but only if you don't do insurance. Right? Why can they provide such a low price? Because they get the drug from the generic manufacturers. There's no such a layered spread pricing, profit making. We did a study. Look at the $100 spent by Medicare Part D on generic drugs. All the players get a much lower share than the spread pricing for PBMs. PBMs got $40 out of 100. And look at the manufacturers, they only got $17. That's their total revenue. Okay, that's not even their profit, that's the total revenue. But then PBM got $40 spread pricing, the profit. So that tells us how much junk going on in this supply chain. Why don't we just go directly to that manufacturer, right? That will save a lot of money for generics.
So gee, it's a little bit like, as you're talking, I'm thinking, so if we actually raised the deductible for pharmacy spend, so that patients will then have to pay actually more of their own money. And the analogy I have, by the way, is, as you're talking, was the auto insurance. If I have a fender bender in my car and have, let's say, a $500 deductible or a $1,000 deductible, let's say on the collision, I can go through the insurance, but I take the risk my premium will go up, right? Or I can go to somebody else and say, I'll pay you cash and just pay for the car. And I think most of us actually go pay cash. to avoid
Yeah.
going through the insurance. It sounds almost like that. Am I wrong?
You're exactly right, John. This is a great analogy. Yeah. And
And
then
one of the-
fundamentally, if I may add, fundamentally, insurance is supposed to cover only major things, right? We don't have insurance cover auto change because that's not efficient. Let's say tomorrow I'm an insurance company. I offer this comprehensive car insurance covering all oil change, any small part, the wiper change. Guess what? I will have zero market share because my premium will be very high and nobody wants me. So I'll be priced out of it. But in our healthcare market, because it's highly regulated, you cannot even design that kind of insurance, efficient insurance product. So there's no such a pricing out mechanism. But if we dare to let the insurance industry innovate, then we'll have great insurance, just like what John mentioned.
Yeah. Again, the question around discount cards, I think, is interesting because we've tried this with our patient population. And, what we've heard at different times is, Walmart won't honor the discount card or CVS won't honor the discount card. And that only works for certain common, medications and not so much in the specialty pharmacy area,
No.
right?
No.
And so, what are the solutions to get around that, right? Because it seems like if a patient has a discount card, they should be able to use it at any pharmacy without any problem.
Yeah.
Right. So problem number one, how do we resolve that so patients can take that, especially if they have an HSA, a health spending account, or, a flexible spending account, they might have those dollars available to them versus, how to treat the specialty pharmacy part of this.
Such a great point. Such a good point, Lisa. So the discount card can only resolve the spread pricing problem for generic drugs. It cannot resolve the rebates inherent in brand name drugs, specialty drugs. Can't. So employers now, many large employers thinking about direct contracting through some kind of not consultant, but some kind of agent dealing with the drug company directly, so get the rebate directly. That's one possibility. Or drug Cuban, they're trying to get into the more expensive drug space. But I think eventually, probably that's where the PBM still can play a role, using their market power. Then we let them handle the very expensive drugs with competition, right? Expensive drug, but then they have some competition, so PBM can extract the large rebates. Then we form some contract. I think that's the only space PBMs can be helpful. For expensive drugs with no competition, guess what? There's no rebate to start with anyway. Then we just have use like stop loss insurance, etc., to pay. And by the way, those are very, very small patient population. It's not like everybody's doing expensive drugs. Yeah.
Right. That's like your MS, your hemophiliac, right? Or, those drugs are just, untouchable because they're so expensive that you need some form of insurance to be able to cover it because, it's $1 million a year or something.
Stop loss is a perfect solution to, as Dr.
And
Bai
I
said,
think as a population, we are ready. Most people are ready to subsidize patients have high risk and low income. I think that's not an issue. But the problem is we are not ready. We are not willing to sponsor not only those patients, but this gigantic inefficient system that channel money to middlemen. We don't like that.
Right. Yeah, I think the middlemen, when I forget who our guest was, but when we were talking about the Johnson & Johnson lawsuit and taking apart the pharmacy pricing, it was astonishing how many parties take a cut of the pharmacy spend, right? From the broker, to the insurer, to the middle, the PBM, the manufacturer. Everybody's got a stake in this. And in any other industry, the way that you cut costs is you go around all of that and you cut out the middle people taking a slice of the pie. And how do we do that in the healthcare industry? How do we cut out all of this? Yeah. And I think you said it earlier, where we're going to have to just go direct in some way to some other form of purchasing for pharmaceuticals. But the industry is so powerful that's like pushing a boulder uphill, right?
I agree with you, Lisa. I think that if we can envision the future, would be just like John said. We have stop loss, but stop loss subsidized by taxpayers and wealthier patients. That's fine. But when we do not put money to sponsor this huge, gigantic middleman system, then the solution has to come. It seems like it has to come from top, right? Our direct pay market cannot flourish unless all this restrictions are freed up, right? Like HIC account and how to design the insurance, what kind of coverage we should have, and the community rating, etc. So there has to be some kind of policy change. However, this is what I learned in BC. You cannot make any policy change unless you change public opinion, right? The policymakers will listen to what the public thinks. Right now, they cannot. They're going to perpetuate the system. You know why? Because the constituencies, the powerful constituencies, are those industries. The public don't even know, right? They're all in fear. We need to have those powerful people take care of us. That's the public opinion. And those powerful industry, they keep lobbying. They make some money, then they put money into a lobbying and other kind of backdoor things to make the politicians happy. So it makes this very stable marriage between the public policymaker and the private players. Looks extremely hard to break, but if more people taste the benefit of the direct contracting, we are going to grow our constituencies. Because once we got the sweet stuff, we are not letting go, right? This is great. We are not letting it go, and the politicians will have to listen. And then once I see my grandma got this great thing, my grandma will tell me, do this. And that is a fundamental, enormous power force, right? Because this, in my opinion, that comes from this unlimited desire from consumers to pursue better quality, better products at lower price.
Spoken like a true free market economist. We love it.
And then we also have providers, physicians, even including insurance companies. They want to make money, want to innovate, want to produce things that patients want. Those two forces are enormous. But now because patients don't have control, and then the industry gets money from the public policy, so they put all their effort to change policy to make patients less and less powerful and make physicians less and less powerful. But then, as I said, we have a way around.
I want to switch gears for a moment slightly, and that listening to your podcast, and again, I'm a big fan of yours. I love your mindset.
Thank you so much.
No, I really do. Your mindset and you're actually, one of your principles seems to be to put cash in the hands of consumers and let them, and it makes sense, right? People buy Tylenol at a good price, and Marty McCary says his mom buys fruits and she compares for apples in one store to another. It hasn't always worked out that way, right? Some of the,
correct.
And then you wrote an article recently about giving cash rather than air conditioners. I thought it was a great piece. But tell me, I mean, it sounds good, but it doesn't always work out that way, especially if you're not an educated consumer. That is one of your principles, right? To put cash in the hands of people and let them be. Kind of reminds me, remember Reggie Herzlinger and her consumer-driven healthcare mantra?
Right.
What do you, I mean, I think that's one of your foundational principles.
Correct, Steve. So let me tell you the genesis of this. I'm really concerned about Medicaid patients. We spend more than like $10,000 on each Medicaid patient. But if I'm a Medicaid patient, if I start a healthier lifestyle, I become healthier. Do I get any reward? Zero. I get no reward. My arrangement is completely made by people I don't even know. They tell me exactly where to go. Am I happy or not? Makes no difference in the system. Am I healthy or not? Makes no difference. I get no personal reward. How can we, number one, incentivize the patient to take a healthier lifestyle? Zero. Number two, how can we give this patient more human capital development opportunities? Meaning that let the patient control the budget and try to look around, try to make a decision. We're literally just saying, look, you don't need to worry about anything. Everything taken care of. How can this poor patient gain personal responsibility and the human capital development, and then can be lifted out of poverty? There's no such a mechanism, right? But then we spend so much money on it at the same time. So I think, and also fundamentally, I believe for incapacitated patients, healthcare is their life. For all other parties, healthcare is their profession or is their business. So it's a fundamental difference, right? So I think the patient, fundamentally, they know they will not make choice that's not aligned with their best interest. So who's the next person is the physician. Physician can help, but other people, I have big concern.
Yeah. Gee, I like the idea of putting the power back in the hands of the patient and the physician, right? Because our industry's gotten so far away from that,
Yeah.
the center of the universe is hospitals and PBMs. And, 80% of the care is between the patient and the physician. It's done in other places. And I think I like the idea of putting the power back there. But one of the challenges I think patients have is nobody knows how to navigate the healthcare system. Even those of us in the healthcare system sometimes are perplexed by, what to do. And it's not as transparent as we like to use the auto industry as a comparison, right? You buy a car, you see your options listed, you can compare a car, from this dealer to that dealer and these options to that option. You know what you're buying, you can look up the quality, you understand the quality you're going to get. It's published if there's recalls and all of that, right? It's very transparent, and pretty much anybody can buy a car, right? But to say, oh, I need to go, have my hip done, and to try to figure out all the costs along the way to completing my hip, and where can I have it done where the quality is good and I'm not going to have infections and I can get it done when I want to get it done, and I know what's included, is mind-boggling to the consumer. So, I look at this and I say we need a complete financial and operational transformation to get to that point, which means that some aspects of the industry are going to suffer in that process. But at the end of the day, the consumer's better off because they have comparability between all the components. But do you see any, traction, legislatively from a regulatory perspective that is looking to move the industry in this direction? Because it seems to me that, we can't wait 40 more years to figure this out. Businesses will go bankrupt, right? And it doesn't seem like there's, there doesn't seem like there's a fire lit under people to, to really get something done in this space.
Great comments. Thank you, Lisa. Yeah. I want to make first point is that once the providers have the freedom and have the sole orientation to serve patients, they can do innovative, amazing things. Think about plastic surgery. Think about the ophthalmic surgical center. Once they deal with cash pay, you go to any plastic surgery center, and then they have the price quoted to you, either up front where you call, they'll tell you, and the price is bundle price. They never tell you you have to deal with 5 different parties, because they know if they do that, patients will leave. So they make it extremely patient friendly. And if you go to those ambulatory surgical centers dealing with cash pay patients, on their website, they will have the price and they have pictures showing shoulder, knee, hip, then just in case you don't understand those words. And then they give you the price saying 100% included, pre-check, anesthesiology, and after check, everything. You just pay me one price, that's it. Those are there's no government telling them to bundle, no government telling them to be transparent with their pricing. They do that automatically because that's their money. They need to compete. So I would say no matter how complicated it is, we want to start small. Let's say we do that with private insured patients. Those are relatively more educated, starting with some states. Eventually, this educational process on both patient side and provider side, provider will know how to really meet patients' needs, and the patients will have better idea how to shop around, starting small. And then we will see many, many different products offered. Insurance company will do all sorts of things to make it simple, make it easy. So I think we should not underestimate the innovative force from all these players. Eventually, in my ideal mind, the healthcare is a service industry. Right now, look at the restaurant. You might want to go to Michelin restaurant. I want McDonald's, right? We have different taste, but then eventually we choose things based on our preference and we are happy. Why don't we also have that kind of system? Maybe John want to only treat high net worth individual, only see 3 patients a day. Fine. But I want to treat lower income patients. They come here, see me only $50, but I see maybe 100. I have a lot of nurses dealing with. That's fine too, and I make good money, right? That, in my opinion, is a much better system, able to meet diversified needs of the market participants.
Yeah. As we start to wrap it up, your thinking to us is clear. Your data is really compelling. It's very strong data. And you've had access to the Congress, right? You've testified, as I understand it. How is it received? I mean, it should be a slam dunk, right? They should say, yeah, I'm going to do what G tells me to do. I mean, you can't argue with it. How were your principles received on the Hill?
Thank you, Steve. I think the members on the Hill, they, even if, let's say, I'm their best friend in their life, they will still tell me, gee, I really love your idea, but I cannot do that because I don't have the political will. So as a professor, I teach students all the time. I think the most important thing is to let people understand, the public understand, starting with more educated, and then, I came from China. I was not a golden girl, right? Receiving all the, the top education background in the United States. However, I do believe those ideas, trying to make the best for me and my family, paying less price, and understand the quality. Those things are not hard. Those things are understood by even people who don't really read. Even grandma, they understand. So if we can somehow demonstrate the value to average Americans, there's a way forward, and there's nothing that can stop it. This is the benefit tasted by all the stakeholders in this newer system.
Believe me, I agree with you philosophically, but that's a pretty big hill to climb when I think of how health illiteracy is. And we shouldn't even call it healthcare. To your earlier point, it's really, I've always said, when I ran the hospital, I don't do healthcare, I do sick care, to your point, because the health of the community, we talk about and give a lip service, and we get not-for-profit status because we do all this benefit. And I know you've published in this space, but the reality is that's not how I make money, right? We make money on people being sick and needing surgeries. And listen, I don't want them all to have heart attacks, but they need a place to go at 3 a.m. when they have that. And that's what we do. But it's not really healthcare, let's be honest. So Ge, I'd love to educate all the consumers, but I think working with the employers seems to be the more efficient strategy, because most people in this country still get their insurance through their employers, and including government payers, by the way, both state employees or big employee groups. And once they get a look at their data and see where they're spending the money, who they're paying, what they're paying for, what they're not getting for their money, I think that will begin to open this up a little bit, because, my perspective is the middle class in this country have been gouged for 20, 30 years because of high hospital costs, high pharmaceutical costs. They're paying higher premiums, copays, deductibles, and their boss, their employer's paying higher premiums too. That money could have gone to wages or investments in the company. So it wasn't the idea of a high deductible plan and an HSA. The idea behind that is to put, as Steve said, more cash in the hands of the consumer so they would make buying decisions. It's kind of like you described. I'd go, I need an arthroplasty or an arthroscopy. I'm going to shop and go to an ASC where the price is listed just like the menu at McDonald's, and I know what I'm getting. Is that the direction we should be taking?
Yes, absolutely, John. But however, we have to understand there are some limitations for employer-sponsored insurance. Number one, it cannot meet diversified needs, right? It's still one size fits all, basically. But you can modify that by making the skinny insurance and let people use their car. However, that insurance, core insurance, is still one size fits all, right? That's number one. Number two, most employers have a very diversified workforce, geographically dispersed workforce. So that makes them extremely weak at the local level. You think you're big, but you have no patient volume to providers. So they have to some kind of build coalition or take advantage of this HRA, right, health rearrangements, reimbursement arrangements. However, if they use the HRA, which means they just give money to their patient, to their workers, saying, here's, $10,000, you guys buy insurance by yourself, I'm done. You don't sue me because I'm done with my job. But then the problem is our individual market is not really functioning. So ACA put a lot of regulations. So we have the premium pretty high. For unsubsidized individuals, very expensive. So I think we have to think about how to make the individual market more innovative, more competitive, so that, even if workers want to go to the market to buy, they have an option for cheaper products. And if the employers want to centralize everything, just like right now, they can do with direct contracting and other channels. But the key is get rid of the middleman as much as possible. Bring doctors and the patient as close as possible.
Yeah, I love that. I love that.
We've covered a lot. Ge, thank you very much.
Thank you.
And as Stacy has said on her podcast many times, I'm a paraphrase, what we consider healthcare waste is someone's revenue,
Exactly.
right? And those 5 companies control 20% of the GDP. The headwinds are fierce. But with all of your knowledge and all of your research and experience, I'm sure you've got layers of opportunities. What do you think is the number one thing that will help us drive healthcare value? We also want to swim in that lane and work together. What do you think is the number one item in your mind to facilitate value-based healthcare?
I think we have to cherish the opportunity in front of us. This is a golden opportunity. Why? We have enormous spending. Our input is so high. Everybody seems like this is public knowledge. And our output is so low. Our health outcome, not healthcare, but health outcome is so low. So now I think at the point that the public awareness of the current system failure is unprecedented. So this calling or the need, right, for change is unprecedented. So that's why I think it's our calling, our mandate. Really, this is a golden opportunity. That we have to communicate to the public that there's a huge opportunity cost. I always felt like we, even all of us, we have limited number of days on Earth, especially limited productive days on Earth. Physicians got all the years of education, not for dealing with all the paperwork. Physicians want to utilize their limited days of primary years to serve patients, right? And then, of course, at the same time, make money. So all these parties not happy. Very, very few people are happy. There is a huge opportunity cost. We can make people healthier. We can make people live longer. We can make physicians serve patients much more productively. So this desire should also be recognized. Then I would say, at the end of the day, people all want money, all want cheaper price, leave more money to themselves, and then better quality, right? Better care. So if we can convey that idea, remove the fear, and let people dare to envision and let them try, then I think we're making a huge cut. Starting from slow, as John said, this is really a maybe really pipe dream, but if we start small, when people realize the benefit, it will grow by itself.
We share your pipe dream, G, for sure.
Thank you.
Yeah. Love your optimism.
Thank you, everybody. What an honor.
There's nowhere to go but up, for sure. And I love what you said about, let's get back to physicians spending more time with patients, have patients have more control of where they spend their money, have more transparency in the pricing in the marketplace, and move from what we have now, which is the most convoluted system on the planet, with lousy outcomes at a tremendous spend, to try to move towards what we value here at the Moving to Value Alliance, try to move much more towards a true free market economy in healthcare, where people know what they're getting for their money and are paying for good quality, and need transparency in that.
If I may add one last one, I'm really trying hard to counter this argument that the people sitting in bureaucracy, sitting in DC offices, know better than people on the ground. That is just not true. I reject the notion that these people have superior morality or superior knowledge. They have neither. They should not pretend to be, and they should let the people have more control.
I think that's a great comment, for sure.
I love that. Well, that's a great closing line. Thanks again to Professor Bai for such a lively discussion with our board members today, and to all of our listeners. Thank you so much, G, for being here today. Appreciate it. Thank you to Steve and Lisa.
Thank you, truly honor.
Thank you.
Thank you so much.
We want to take a minute now to introduce the new MTVA membership program. As a 501c3 nonprofit, we rely on support from our grassroots network to advance our mission of creating a value-based health system with high-quality patient outcomes at a reasonable cost. As we continue to grow and broaden our impact, we're excited to invite like-minded organizations and individuals to join our membership program. We're proud to offer two membership models, Ally Member and Trade Member. Tax-deductible membership contributions help us enrich the healthcare environment with quality content, including this podcast, and robust platforms to fuel discussion, collaboration, and advocacy that lead to groundbreaking solutions. For more information, including a full list of benefits offered, visit our website at www.movingtovalue.org/trade-member. The link is also in the episode description. Thanks again for listening and for being part of this important movement.